intercostal nerve block. Hopefully you had the chance to watch the first lecture, which give you the fundamentals of truncal regional analgesia, a lot of anatomy, and then for each of these blocks, as you see here, I have a separate video. This is the most important anatomical picture, especially for this video. We're talking about the intercostal nerve block. So this is the spinal nerve anatomy, typically between T2 to T11 to 12. And the spinal nerve started by the union of the ventral and dorsal roots. The spinal nerve is really a small nerve, and very quickly it bifurcates to the ventral, which in our case here, the intercostal nerve, and dorsal, and the dorsal give you the medial and lateral branch. The lateral branch continue as posterior cutaneous. Now, the intercostal nerve has two main branches. The lateral cutaneous branch, usually about the mid-axillary level, and closer to the sternum, it gives you the anterior cutaneous branch. So, as you see, the lateral further divided into anterior and posterior. The anterior further divided into middle and lateral. So when I'm doing an intercostal nerve block here, then I should get the lateral and the anterior, but not the dorsal rami. So this is important. Why? One of the common indication for this block, in the chronic pain, we do it for intercostal neuralgia, but sometimes we do it for persistent post-herpetic neuralgia. So for persistent post-herpetic neuralgia, if the pain and the rash, usually it goes with the rash, if the pain goes all the way back to the midline, then we have some innervation from the dorsal rami. So doing intercostal block in this case is not enough. But if we have intercostal neuralgia that's not reaching the midline in the back, mostly lateral, anterior, then yes, intercostal nerve block is a good option. So thoracic spine from T1 to 11, T2 mainly to T11. As I showed you, there is anterior rami, which give you the intercostal nerve, and the intercostal nerve give you many branches at it, wrap around, walking or going with the rib. So the collateral, lateral, anterior cutaneous, and some pleural branches, peritoneal sensory branches. Usually the first upper 6 intercostal nerve supply the parietal pleura, skin, serratus posterior, levatorus, costerium, and intercostal muscle. The lower 5 intercostal supply usually structure in the abdomen, mostly abdominal, wall muscle, and peritoneum. So how we do it? So position your patient in a prone position, use a linear transducer, scan in a sagittal plane. I will show you in a minute a few pictures. Start from midline to lateral until you start to see the ribs. Identify the structures and the vessels. Advance the needle in plane. The needle tip should be continuously visualized to avoid serious complication. Inject 5 ml of local anesthetic and it's crucial to aspirate for blood to ensure the needle is not intravascular. Remember, the vein and the artery run with the nerve in the same plane. Separate the internal intercostal nerve, so between the internal intercostal nerve from the innermost intercostal. So by far, this is the deepest um, uh, truncal block if we exclude the paravertebral, of course. Nerve block, intercostal nerves and its branches. Indication, breast surgery, chest wall surgery, analgesia for the chest tube, rib fracture, sternal fracture, costochondritis. And as I mentioned, for in the chronic pain, we use it for intercostal neuralgia and any pain along the distribution of the lateral and anterior branches of the intercostal nerve. And sometimes post-herpetic neuralgia, but you have to make sure it's not reaching the midline in the back. Contraindication, general contraindication, complication, pneumothorax, hemothorax, last, very high absorption here. You're just literally putting it next to the artery and vein. Side effect I would call difficulty in breathing. And this is very important and often missed when you are doing block and or denervation for this intercostal nerve. Make sure you don't do more than 3 level, because guess what? From T7 to T11 you get the innervation for the abdominal wall muscle, and that will cause a lot of weakness and the patient can complain of difficulty of breathing. Now, let's look at this picture. So starting from above, you have the skin, under the skin, the subcutaneous tissue, and then you have the trapezius muscle here, and erector spinae muscle, and then you have the external intercostal muscle, underneath that the internal intercostal muscle, and the innermost is the innermost intercostal muscle. So our target is between the internal intercostal muscle and innermost intercostal muscle. So the orientation of this, it's vein at the end, then artery, then nerve. It is very hard to see the nerve, but if you see the artery, then it's just lateral to that your nerve. So again, trapezius, erector spinae, and then the intercostal muscles. It's hard to differentiate them sometimes, but I will show you a trick in a second. So here, the way to differentiate whether you are in the right plane or not. So let's say you put your needle here, you touch the rib, you put some medication to see. So if the spread of the layer going upward, then that's most likely you're still superficial. What I would like to see it's going downward like this. Why? Because you are pushing the innermost intercostal muscle down by putting the medication here. So you will see the push is going down, pushing the pleura down. That's the typical spread for the intercostal nerve block. Now, what I would highly recommend you do when you do this is to scan from midline and go lateral. So as you see here, there are 5 different blocks we can do at this area. Starting from 1, this is the retrolaminar plane block. As you see here, you don't see any TP, you don't see any ribs. Then go more lateral at number 2. Here you can do the paravertebral or the erector spinae if you go above the TP. And then go scan more lateral. you will see the rib. Now the rib is more circular, and you can differentiate that from the TP. And it's okay, you can slightly go outer to find your sweet spot. Usually, the more you go lateral, the more superficial the structure become. So you really want to see the pleura very clear and find the target there. Then if you keep going lateral, you will see the rhomboid muscle. That's if you go very close to the scapula, and then you can do the rhomboid plane block here. Thank you for watching.